focusing on emergency and urgent healthcare for people who do not or cannot access such healthcare within the golden hour. So we plan and provide and make sure that people are not losing lives on roads trying to get to the bigger cities to access healthcare. So the end of the life, as sir said, we experiment a lot with ICT, and I feel ICT is the only way that we can actually promise healthcare to the populations that we are working in. We have a major lack of doctors. The infrastructure is not an issue. Technology is not a very big issue for us. We can access very good and very high-end technology as and when we need it. But the problem is the stakeholders must be willing to accept that technology, and we must have enough human resources to implement that technology that we get for them. The lack of doctors is especially glaring in the small towns that we work in. So as I think statistics everybody knows, we have so many patients. We have around 30 million cancer patients, and every year we produce only about 84 DM oncologists. And we have the double number of diabetics. We have around 60 million diabetics. We are diagnosing 10 million every year, new diabetics. And we are producing only 67 DM oncologists every year. So how do we make sure that the community can access these super specialists, these star doctors that are sitting in the big cities who can actually promise them good healthcare? The villager is very loath to come to the hospital to just get his blood sugar level checked, or just to maintain his blood sugar levels, or just to ask the doctor, that this is my blood sugar is 200 today, what should I do about it? So we make sure that the villager does not need to come to the hospital to make these small adjustments in his dose or these small consultations. Primary healthcare is the way to go. So we've started some telemedicine solutions, and this is where we found out that the end of life can come very quickly in a technology. The telemedicine solution that we started in, so we studied why and how telemedicine is failing so consistently. It is one of those healthcare technologies that has failed every time that people have checked on it. I think 4 or 5 years when we were attending conferences, there used to be one session on telemedicine always in every conference, and now it's nowhere there. So we tried to find out why this telemedicine was failing so consistently and regularly in all healthcare delivery models. And then we realized that until and unless a doctor can see a patient, can actually touch and feel a patient at least once in his life cycle of the disease process, it is very difficult for both the doctor and the patient to be satisfied. So we realized that the current telemedicine projects were running thousands of miles apart from the patient and the doctor. So they had to be closer together. So we started telemedicine projects about 20 to 30 kilometers away from our hospital in the big villages that were surrounding him. Even with that, we could not really succeed because the apps were so heavy on data. It was so difficult to convince the stakeholders, the doctors, to spare time regularly for this. And we realized that with new technology coming in very quickly, new apps coming in, there are a lot of very good telemedicine solutions that we are seeing here also being displayed, and we are talking to them. The old telemedicine had an end of life which was only 6 months to a year into its life. People found out very good shortcuts. As sir said, consultants come up to you and tell you that this is much better, why don't you try it out? So we see that end of life in ICT can come very quickly and abruptly, and we have to be prepared for it and have backups ready. So preparing 10 years in advance may be a good idea for your SAPs and datas and preserving them, but I'm not very sure how quickly it will die out and how quickly you will have to prepare an alternative model to just keep a backup for that.